Hi everybody, welcome to my YouTube channel Dr.Sreenivas Medical Concepts and my FB page Dr.Sreenivas Concepts. This is Dr. Sreenivas, neurologist from Rajahmundry, Andhra Pradesh, India. I am also the medical author of the book Focused Neurology. My email is cklpm@gmail.com. Today I want to talk about a very fascinating topic, the lobar functions made lucid. Lobar functions made lucid. Cognitive Neurology, Part 15, lobar functions made lucid. Lobar functions. So we are going to talk about the functions of the frontal lobe, parietal lobe, temporal lobe and occipital lobe. So first we'll talk about the frontal lobe. It is the largest lobe of the brain. The most anterior part of the frontal lobe is the prefrontal cortex, dorsolateral prefrontal cortex, which is the seat of the executive functions, namely planning, programming, judgment, abstract thinking, motor sequencing and set shifting. The mediofrontal and orbitofrontal cortex are responsible for personality traits and motor and social inhibition. So first we'll talk about the dorsolateral prefrontal cortex, the executive functions. How do we test? Ask the patient to produce as many words as possible in 1 minute, starting with the letters F, A and S. Ask the patient to name animals, fruits or vegetables, as many as he can in 1 minute. More than 10 is normal, less than 8 is abnormal. Look for perseveration. Motor luria test. Fist, edge and palm test. Motor luria test. Fist, edge, palm test. The patient is explained by the doctor by doing it himself. Make a fist and tap on the flat surface with the thumb upwards. Then straighten out fingers and tap with the ulnar border of the hand and then place your flat palm on the surface. Once the patient has understood, ask the patient to repeat it. This is motor luria test. We have luria graphic test. Patient is asked to draw alternating sequences like a triangle and a square of being shown by the examiner. So patient is asked to draw alternating sequences like a triangle and a square. This is luria graphic test. Next is set shifting, trail making test. We put different numbers in a random manner and we ask them to connect the numbers sequentially. So you can see a 17, 21, 1, 3, 10. So we ask them to connect the numbers sequentially, 1 to 2, 2 to 3, 3 to 4 in a sequential manner. This is known as set shifting and trail making test. So these are all the executive functions to be tested in the dorsolateral prefrontal cortex. Now let's see how we can test orbitofrontal cortex and medial frontal lobe. We test it by go, no-go test. Go, no-go test. Ask the patient to make a response to one signal, the go signal, example tapping, and not to respond to another signal, the no-go signal, that is they will not tap. So patient is asked to tap once when the examiner taps once and stopped when the examiner taps twice. So this is known as go, no-go test. Interpretation. Difficulty in withholding a response suggests a lesion in the ventral part of the frontal lobes. So this is go, no-go test. Next we test a test known as the Stroop test. This test examines the patient's ability to inhibit his responses. Patients are asked to state the color in which words are printed rather than the words themselves. Ask the patient to tell the color of the letters in the following. For example, RED, but it is given in blue. So they have to tell it blue and not read it as red. BLUE, again tell the color. BLACK, they should not say as black, orange. WHITE, they should not say as white, a light blue colored. So patients are asked to state the color in which words are printed rather than the words themselves. This is known as the Stroop test. Yeah. So what are all the important functions of the frontal lobe and what are the effects of damage of the frontal lobe? The functions of the action of the frontal lobe. It is responsible for the personality, emotional control, social behavior, contralateral motor control. So the frontal lobe gets affected, they'll develop hemiparesis on the opposite side because the corticospinal tract crosses the medulla oblongata and goes to the opposite side. So they would develop contralateral motor control. Language, Broca's area is there in the frontal lobe. So if the Broca's area gets affected, they have Broca's aphasia, that is the fluency gets affected, and micturition. The bladder center is there in the medial part of the frontal lobe. So if it gets affected, persons have problems with the micturition. So the functions of the frontal lobe, the actions of the frontal lobe are personality, emotional control, social behavior, contralateral motor control, language, and micturition. What are the effects of damage? Cognitive and behavioral. They'll have disinhibition, they have lack of initiation, they have antisocial behavior, impaired memory because the immediate memory or the working memory goes to the dorsolateral prefrontal cortex. So if the frontal lobe gets affected, they'll have problems with immediate memory. So they'll have impaired memory. They'll have expressive dysphasia, that is Broca's aphasia where fluency is affected, and they'll have incontinence. So cognitive behavioral, disinhibition, lack of initiation, antisocial behavior, impaired memory, expressive dysphasia, and incontinence. What are the associated physical signs as effects of damage? They'll have impaired smell because the olfactory nerve goes to the frontal lobe, so the smell gets affected. They'll have contralateral hemiparesis because the corticospinal tract gets affected. They have frontal release signs. These are known as primitive reflexes, that is the palmomental reflex, avoiding reflex, grasping reflex, sucking reflex. These are the reflexes which are present during our infancy. But as the brain, especially the frontal lobe, gets matured, these reflexes should disappear. If there is a persistence of these reflexes or disappearance and the re-emergence of these reflexes, it indicates in the first place either the frontal lobe has not developed well or the frontal lobe has developed well, after some time it has become dysfunctional. So presence of frontal release signs. So the associated physical signs are impaired smell, contralateral hemiparesis, and frontal release signs. The positive phenomena are that they may have seizures and versive head movements. The frontal eye fields area number 8 is responsible for saccadic movements. When it gets stimulated, the eyes will be pushed towards the opposite side. So if the frontal eye fields area number 8 gets affected, or if it is irritated, gets stimulated, the eyes will go to the opposite side and the head also will turn to the opposite side because the sternocleidomastoid has got a predominant unilateral innervation. So if it gets stimulated, the head and eyes will go towards the opposite side. So this is known as versive head movements, seizures. So it indicates that the frontal eye fields area number 8 is affected. So these are all the functions and the effects of damage of the frontal lobe. Next we'll talk about the parietal lobe. Parietal lobe, the dominant and the non-dominant. Dominant is left side cortex and non-dominant is the right side of the cortex in right-handed individuals. The functions of the parietal lobe are language, especially the temporoparietal lobe. We have the vernix area, so it is responsible for understanding comprehension, and we have the angular gyrus in the dominant hemisphere, which is responsible for reading. So if the angular gyrus gets affected, they can develop a Gerstmann syndrome, the components of alexia, agraphia, finger agnosia, right-left disorientation. So the language, especially the calculation, reading, writing, and comprehension are the functions of the dominant parietal lobe. So what are the effects of damage? Behavioral and cognitive. Dysphasia, agraphia. They can develop vernix aphasia, they can have problems with alexia and agraphia. They'll have dyscalculia, they have acalculia, apraxia. What is apraxia? Difficulty in performing a learned motor act despite motor sensory coordination and comprehension being normal. So if the parietal lobe and the parieto-frontal connections get affected, they'll develop apraxia, ideational apraxia, ideomotor apraxia. They'll not be able to perform a learned motor act. If they have problems with imagination, it is known as ideomotor apraxia. If they have problems with the performance of actual movement, and when they go out of sequence, we call it as ideational apraxia. And then finally, difficulty in using the limbs, we call it as limb kinetic apraxia. So we see apraxias if the non-dominant parietal lobe gets affected, especially ideational, ideomotor, and limb kinetic apraxia. If the non-dominant parietal lobe gets affected, they'll have constructional apraxia or dressing apraxia. It is more to do with the spatial orientation. And if the parietal cortex gets affected, they can have asimultaneognosia, where they cannot integrate the center with the periphery of the vision. It's one of the important components of the balance syndrome. So the behavioral and cognitive effects of damage are dysgraphia, agraphia, dyslexia, acalculia, apraxia, agnosia, that is asimultaneognosia. The associated physical signs are, as frontal lobe is responsible for the movement, the parietal lobe is responsible for sensations. So if parietal lobe gets affected, contralateral hemisensory loss will be present. So the associated physical signs are contralateral hemisensory loss, astereognosis. They will not be able to identify if an object is placed in the hand by closing their eyes. They cannot identify by manipulating. So for example, if a keychain is put in the hands, and if they are asked to name, they even despite manipulating with the fingers, they are not able to say it. This is known as astereognosis. Then they can have agraphesthesia. If the person is asked to close the eyes and a number is written on the hand, and if the person is asked to say what number is written, they are not able to tell it. That is known as agraphesthesia. Contralateral homonymous lower quadrantonopia. The optic radiations go in the parietal lobe and the temporal lobe. So if the parietal lobe gets affected, the optic radiations get affected, and therefore they'll have homonymous hemianopia, but the inferior quadrant gets affected because the representation is on the opposite. Parietal lobe represents inferior quadrants and temporal lobe represents superior quadrants. So the parietal lobe gets affected, they'll have inferior homonymous quadrantonopia. And then they have asymmetry of the optokinetic nystagmus. As I said, the frontal lobe is responsible for saccadic movement. Frontal eye fields area number 8 will push the eyes to the opposite side. The parietal lobe is responsible for pursuit movement, following movement. So the parietal lobe gets affected, the following movement gets affected. So optokinetic nystagmus, there will be an asymmetry of the optokinetic nystagmus where the pursuit movement gets affected. So these are all the associated physical signs as effects of damage of the parietal lobe dominant. Contralateral hemisensory loss, astereognosis, agraphesthesia, contralateral homonymous lower quadrantonopia, asymmetry of the optokinetic nystagmus. The positive phenomenon is focal sensory seizures. Since all the sensations finally go to the thalamus, and from thalamus thence to the parietal lobe, they can have focal sensory seizures. Now we'll talk about the parietal lobe non-dominant. The functions are the spatial orientation and the constructional skills. Why the non-dominant parietal lobe is concerned with the spatial orientation more than the left parietal lobe? The right parietal lobe controls both the right and the left extrapersonal space, whereas the left parietal lobe only controls the right extrapersonal space. So in the left parietal lobe, the dominant parietal lobe gets affected, the right extrapersonal space gets affected, but this is compensated by the intact right parietal lobe, which controls both the right and the left, and therefore left parietal lobe usually does not produce right hemi-neglect. But if right parietal lobe, the non-dominant parietal lobe gets affected, both the right and the left extrapersonal space gets affected. The right extrapersonal space is compensated by the intact left parietal lobe, but there is no compensation on the left side. So right parietal lobe lesions will develop left hemi-neglect and spatial disorientation. The orientation gets affected. So the functions of the parietal non-dominant lobe are spatial orientation and constructional skills. The cognitive and behavioral effects of damage are neglect of the contralateral side. So when the right parietal lobe gets affected, they'll completely neglect on the left side. So much so that if it is severe, if you pinch their hands, they'll ask whose hand you're pinching at. At bedside, it can be tested by asking them to put all the 12 numbers evenly as a clock. They'll put all the 12 numbers on one side and completely neglect on the left side. So this way we can test the hemi-neglect. So they'll have neglect of contralateral side, spatial disorientation, constructional apraxia and dressing apraxia as a manifestation of spatial disorientation. So the cognitive and behavioral effects of damage are neglect of the contralateral side, spatial disorientation, constructional apraxia and dressing apraxia. The effects of associated physical signs of effects of damage are contralateral hemisensory loss, because all the sensations from thalamus goes to the parietal lobe. So they'll have contralateral hemisensory loss, astereognosis, agraphesthesia, contralateral homonymous lower quadrantonopia and asymmetry of the optokinetic nystagmus. The positive phenomena are focal sensory seizures. Now let's see the occipital lobe functions. The functions of the occipital lobe are visual processing. From the eye, finally all the visual information goes to the occipital lobe and it processes the visual information. So the main function of the occipital lobe is visual processing. And the cognitive behavioral effects of damage are visual inattention, visual loss, visual agnosia. Despite eye being normal, the person is not able to give meaning to what they have perceived visually. This is known as visual agnosia. The associated physical signs are they'll have homonymous hemianopia on the opposite side, but macular sparing may be there. There are two reasons are that macula is supplied not only by the PCA posterior artery but also by the MCA, and second, macula may have a widespread representation and therefore the macula is usually spared. So they'll have homonymous hemianopia with macular sparing. The positive phenomena are that they'll have simple visual hallucinations like phosphenes and zigzag lines. Next we will see the temporal lobe, the dominant lobe. The functions of the temporal lobe are auditory perception. Whatever we hear finally goes to the temporal lobe and it processes the auditory information. The language, vernix area is there in the temporal lobe. It is responsible for understanding or comprehension of the language. Verbal memory, the speech, the memory of the speech goes to the language, goes to the temporal lobe, the dominant hemisphere. Smell and balance. So the functions of the temporal lobe are auditory perception, language, verbal memory, smell and balance. The cognitive behavioral effects of damage are receptive aphasia. They'll have vernix aphasia. They'll not be able to understand. So if a doctor has something, the patient may say something else. So because they don't understand, comprehension is affected. Receptive aphasia. They'll have dyslexia, difficulty in reading, impaired verbal memory. The associated physical signs are contralateral homonymous upper quadrantonopia. The parietal lobe is responsible for inferior vision and the temporal lobe is responsible for the superior vision. So if the temporal lobe gets affected, they'll have homonymous hemianopia, superior quadrantonopia. The positive phenomena are that they'll have complex hallucinations of smell, sound, vision and memory. Finally, we'll talk about the temporal lobe, the non-dominant hemisphere. The functions are again auditory perception, melody pitch perception, non-verbal memory, that is memory to do with the non-language functions. For example, as the water gushes out, it makes sound. If the vessels are dropped on the floor, it makes sound. So these are all known as the non-verbal sounds, and this non-verbal memory goes to the non-dominant hemisphere. And then smell and balance. So the functions of the temporal lobe non-dominant are auditory perception, melody pitch perception, non-verbal memory, smell and balance. The cognitive behavioral effects of damage are impaired non-verbal memory, impaired musical skills, tonal perceptions. The associated physical signs are contralateral homonymous upper quadrantonopia, and the positive phenomena are complex hallucinations, smell, sound, vision and memory. So these are all the important concepts of the four lobes: the frontal lobe, parietal lobe, temporal lobe and occipital lobe. So these are all the lobar functions which have been made lucid. The important concepts of neurology I put in my book Focused Neurology in a question answer format, written by Dr. Sreenivas. It is available online from all the leading booksellers including Amazon. If interested, it could be bought online. So these are all the important functions of the Lobar functions. The Lobar functions made Lucid. I hope you have enjoyed listening to my lecture as much as I have enjoyed delivering it. If you have enjoyed it, please like it, share it, and subscribe it. And you can connect it to you can connect yourself to my email sreeklpm@gmail.com. But please like and subscribe my YouTube channel, Dr. Sreenivas Medical Concepts, and my FB page, Dr. Sreenivas Concepts. Thank you. Bye.